Good afternoon. Welcome to this new PCR webinar on tricuspid valve from diagnosis to new treatment options. I am Pepe Zamorano, Head of Cardiology at the University Hospital Ramón y Cajal in Madrid, and sitting with me here in the EuroPCR studio is Alain Berreby from Paris. Welcome.
Thank you.
We have also in the studio Axel Linke, interventional cardiologist. Welcome.
Hello.
And also here we have with us Henrik Triedi from Germany, and he is an interventional cardiac surgeon. What this means? What is an interventional cardiac surgeon, Henrik?
Well, as a surgeon, I was concentrating on especially minimally-invasive surgery in valves from early on. And from there, it was a small step into interventions. So I also had the chance to work on transcatheter-based interventions from the early days on. And yes, that's what I do. I do both.
Excellent, clear explanation. So, Alain, you are really an expert in interventional imaging. What can we do in imaging here? Why imaging is sitting here in this webinar?
Imaging is playing a key role for patient selection, to diagnose the disease, to try to select the appropriate patient for each intervention. And in the case of transcatheter therapies, it is very helpful to plan the intervention and to guide the intervention during procedure.
Clear. Henrik, what about, is the surgical procedures going down because Axel is doing more interventions? Or what is happening in your country?
Well, I have to say on the mitral side and tricuspid side, the numbers are going up because we see more patients and they are now pretty much more in the focus. While on the aortic side, definitely due to TAVI and maybe also due to Axel, the numbers are going a bit downwards.
Yeah. And Axel, then interventional valve is only for the aortic valve, or what is your perception here?
I mean, most of the structural time is still dedicated to aortic valve replacement. But due to the growing opportunities on the mitral and tricuspid side, the numbers are increasing here as well.
So thank you. So why are we sitting here? I think that no doubt that what we want is to increase your knowledge in tricuspid regurgitation. We would like to discuss, and we want to discuss new therapeutic options, and no doubt that we want to know more about the new diagnosis, the new treatment of the patients, and how to follow these patients. Well, I think that is quite important, and this is a slide that you can see, a recent study that we did in Madrid. We have included prospectively more than 35,000 consecutive patients entering in different echo labs. And as you can see here, really tricuspid regurgitation is really relevant. So more than 6% of those patients showed at least moderate or severe tricuspid regurgitation. And is this relevant to our patients? Indeed, it is. And as we published a few years ago, the new grading classification, you can see that now we differentiate mild, moderate, severe, massive, or torrential tricuspid regurgitation. And why are we doing that? Well, I think that there are two things that we will see later during the discussion and the presentations. First, because really it makes a difference. I mean, the prognosis is different from our patients with massive or torrential than patients with severe. So they die more and they are hospitalized more. We also know that even having mild or mild to moderate tricuspid regurgitation impacts in the prognosis. So I think that with this in mind, let us move to the first step, which is the imaging part, how to follow, how to diagnose, what we need to know about the tricuspid valve. Alain?
First of all, we would like to remind you the anatomy of tricuspid valve, which is, as you know, AV valve. We have 3 leaflets. Sometimes and very frequently, the anterior leaflet has a cleft in the middle. It is very important to detect that by 3D echo. We have the posterior leaflet, we have the septal leaflet, and we have very important surrounding structures like aortic valve. Aortic valve is very important as a landmark for 3D echo. We have also the AV node, the coronary sinus, and almost the right coronary artery, which is something very important for surgeon as well as the interventional cardiologist. If we summarize the respective roles of multimodality imaging, we have the echo, the gated CT scan, and the CMR. Echo is critical for assessing TR severity. We have seen that with you, Pepe. And for valve analysis, and particularly in the interventional process, guiding and control the immediate result. CT scan is more dedicated to the planning of the intervention, particularly annular size, the angle of the X-ray, and the proximity of the right coronary artery. CMR is more dedicated to the right ventricular function and enlargement and remodeling, which is particularly important for the prognosis. With these different modalities, we are able, with clinical exam, to differentiate the three types of TR. The primary TR with organic disease, the secondary TR, which we call functional TR, which will be the main issue during this webinar, and the isolated TR, particularly seen in old female with a long history of atrial fibrillation. We define three stages of clinical TR. The stage 1 is when TR severity is non-mild. The dilation of the annulus is not important, less than 40 millimeter. And with the coaptation mode, we have a normal coaptation mode and no tethering. So normal coaptation, no tethering. In this situation, we have a medical treatment, no intervention is needed. In stage 2, we have a mild, moderate TR. We have an annular dilatation above 40 millimeter, and we have a coaptation mode which is abnormal, edge to edge, less than 3 millimeter, but no tethering, inferior to 8 millimeter. In this situation, we have the indication of tricuspid valve annuloplasty, which should be carried out if tricuspid annulus is above 40 millimeter, even if we have mild TR. It was proposed during ESC guideline published in 2017, as well as a US guideline.
Alan, let me ask you a couple of things, because there are coming questions from the audience and we need to have a live discussion. Well, I will take the first one, which is what is the main difference between torrential and massive? Let us clarify to the audience that is based in the echo parameters, if you agree. So, in fact, when the vena contracta is between 14 and 20 is massive, and more than 20 then is torrential. And then let me ask you, do you think that after just showing the guidelines and the thing about the severity of tricuspid regurgitation, Hendrik, do you think that is there too late sometimes to operate a patient, or we should operate? And I will do the same question also to Axel.
Yes, when it comes to surgery, we always discuss bad results of surgery for isolated tricuspid repair, and definitely that's true. 10% mortality in those patients who are treated isolated. But why is it? It's not due to the risk of surgery, it's due to the selection of patients. And if you have torrential TR, very often you have very bad ventricular function, and in those patients you might see worse results, and this is why we potentially need a better patient selection, or we should come earlier in the treatment.
So he said an important number. He said the mortality in isolated TR is close to 10%. What is your mortality in these type of patients?
Yeah, with the transcatheter techniques, based on the personal experience and study results, the acute mortality is definitely lower than that. But the problem as compared to surgery is that we don't have long-term results, and technically we cannot address some of the patients that Hendrik is going to address with surgery.
And Alain, before moving, there is another question coming from the audience. It's quite active. When should we consider treating TR based on imaging?
Yes, it is multifactorial assessment. It is a hard team discussion for sure, and imaging plays a key role, but not the sole. We have to discuss the clinical status, the comorbidities, the right ventricular function, and so on. So, and the operative risk for sure. So it is a hard team discussion for sure. It is not only based on imaging.
Please move forward.
So in this setting, in this stage 2, when you have a mild or moderate TR with annular dilatation, we have a class 2A indication with a level C of evidence to propose surgery corresponding to a ring annuloplasty. Please note that in the last EuroHeart survey just published 1 week ago by Bernard Jung, 32% of patients receive tricuspid surgery during mitral valve surgery. So it is close to my experience, which is around 40%. And again, it is important to remind you the ring annuloplasty offers a better durability of the result than the patient which have not a ring annuloplasty in terms of surgical treatment.
But then let me ask you, Axel, then do you think that the way showing to these really results and the graph, do you think that then the repair via remodeling of the ring is the way to go? Or we have different patients, different options?
I think we first have to understand what is the reason of TR. Is it the true annular dilatation of like more of an atrial disease? Or is it like a worsening of the right ventricular function with tethering on the leaflets? And based on the basic mechanism of the disease, I think treatment options are diverse. And in some cases, it might be necessary to combine different transcatheter treatment options.
And Henry, we do have a question clearly for you. I mean, we have seen the ring, different options, right ventricle, and here the question is there any threshold for pulmonary pressure to really treat the patient, or just saying that it's too late?
Yes, I think this is a very important question actually, because it's all about RV function and all about also pulmonary hypertension. But there's no real threshold, because it also depends if the pulmonary hypertension is still treatable, if it's going down on a medication or not. So there's an average threshold, I would say, of about like 80 millimeter mercury and above, then you really are in trouble. Because finally, what we end up in surgery, since we have a more effective treatment for the disease, since we usually get rid of the TR completely, we have the problem of afterload mismatch. All of a sudden, the right ventricle has to bear the complete afterload. And this sometimes is very hard for the right ventricle to stand. And therefore, we have to have a look at these thresholds. And, but it's not only the pulmonary pressure, it's also a combination of right heart function and other values we have to look for.
So Alain, please continue. Yeah.
Finally, the stage 3, corresponding to our patient, more or less, with a very severe TR and sometimes torrential. Annular dilatation is very important, largely above 40 millimeter. We have no coaptation, and particularly when it is above 7 millimeter, it is particularly important. And we have in this situation very often a right ventricular enlargement and dysfunction. And it is in this category of patient we have a severe tethering above 8 millimeter. And in this situation, with exclusion of severe RV dysfunction, severe pulmonary hypertension, and comorbidities, we distinguish 2 categories of patients. Low risk, operable, which can be operated by surgeon with the tricuspid repair with adjunctive technique like a patch enlargement, you will elaborate on it, or more often a tricuspid valve replacement. And in high risk or inoperable patient, it is at this moment we consider transcatheter technique. And it is important to show this last slide corresponding to the study of the Trivalve registry just showed during the last TCT meeting in San Francisco where the transcatheter therapy was associated with a significant greater survival and survival free from heart failure rehospitalization.
Wow, this is really hot information. Thank you for that, Alain. I think a few days ago this was published. And I have, with this slide, I want to go back to Hendrik because we have, again, a very important question from the audience. The audience is a little bit worried about your data that you said 10% of mortality. Maybe we should differentiate that this was clearly related to the isolated TR. So maybe we need to clarify this. And also the question is that don't you think that this 10% mortality is related to old studies where heart cath was not performed regularly?
Yes, I'm convinced, actually, because we have our own personal experience. And if you have a good patient selection before surgery, you can achieve excellent results that look much different from what has been published in the past. With this particular slide that Alain is showing here, I have a couple of problems, knowing that in the trials, the safety and efficacy trials that have been published on the clip, for example, on the band, half of the patients still had severe TR. I really wonder how we can see such a survival difference. And I think we have to dive more deeply into the data to really find out if this was a valid comparison or not. I have my doubts, but it's a clear vote for randomized trials, because only then we will find out the difference and the truth.
Axel, any comment here with this slide?
I mean, especially with regard to the overall survival, at least those results are compelling, but I'm completely in line with Hendrik. Despite of the fact that this is a propensity-matched analysis, we have to understand of whether there are patients that benefit and others that did not, and whether the amount of TR reduction was associated to survival benefit.
It's clear that there is no doubt that we need to better select the patient and work as a team. So then let us move forward. What are the new treatment options? Axel.
Thank you. So basically, there are a couple of treatment options that are summarized on these slides. So we have annuloplasty as a suture or ring-based system. We have coaptation enhancement. We have direct replacement and alternative techniques that involves implantation of valves into the venous circulation. Just starting with one that was initially developed to treat mitral incompetence. And in an off-label attempt, those technology was also used on the tricuspid side to reduce TR. The initial experience was gained with a small mitral clip, the NTR, but especially the availability of the bigger one, the XTR, with a span of 22 millimeters, might enable us to treat patients even in later stages of the disease. Another advanced technology is the Pascal device. This is also an edge-to-edge repair technique. Although this device is a little bigger with 2 pedals and a spacer in the middle. The pedals are wider and a little longer. And this spacer in the middle also enables to close for leaks that might occur in between the leaflets. You have a guiding catheter and a steerable catheter that enables you to maneuver the catheter inside the right atrium and achieve different positions to connect the septal with the posterior, the septal with the anterior leaflet. There's this is also off-label use at the moment, but interventionalists are trying to explore this technology a little more in the studies. A ring annuloplasty device is a Cordiband that you can see here. The implant is connected to the annulus of the tricuspid valve using different kind of anchors that are drilled into the tricuspid annulus. And at the end of the procedure, the tricuspid annulus is contracted using a nitinol wire that is running through the implant. With this kind of device, we have seen in the tree repair study a 16% average annular reduction from 44 millimeters to 37 millimeters, which in general tells you that this system is working. And as you can see from the left side, the treatment effect was seen in all of the patients. In addition to that, and this is basically limited to clinical studies at the moment, we have valve technologies of self-expandable valves predominantly that are implanted directly into the tricuspid annulus, and all of those technologies are currently investigated in clinical trials.
But then before moving to surgery, I think that we have seen a wide variety of possibilities of new treatment options. But Henry, for example, in the tricuspid regurgitation, we don't have a huge experience in clipping the valve. We have an Alfieri in the mitral valve, but we don't have a technique that was widely used. So it seems that for TR we have used annulus in surgery. Is that right, and why?
Yes, the main part of surgery for tricuspid valve has been annuloplasty, but there have been techniques, as I will show in my presentation, that also dealt with the leaflets, and there was a MitraClip-like surgery approach, the Clover technique, where you fixed all 3 leaflets in the middle with a suture, so thereby also gaining a kind of an edge-to-edge repair. But this has not been done in many cases, and actually also the long-term results of this technology without a ring has not been very good.
Yeah, and then, Alan, I think that we have seen this variety, this huge wide menu of things that Axel offers us to our patients. Do you think that imaging is crucial to really move towards a part of the menu to one technique or the other, or how to select the patient?
That's still a controversial issue, and we have still to define the appropriate patient for individual technique. And we have to confess, it is not yet established, and we have to choose for individual patient at this moment the best technique with a team discussion. For sure, we have seen that most of the patients are on the stage 3 with a massive and torrential TR, with annular dilatation, tethering, right ventricular dysfunction, but not too severe. So probably, as you say in the beginning, we send the patient to transcatheter therapy maybe too late. And the appropriate patient, for sure, has to be with no calcification, but it is very rare in tricuspid, has a dilation of the annulus. Coaptation gap has not to be too massive, above 14, for example. And the lead pacemaker is not really favorable for edge-to-edge. And again, he has to be close to the anteroseptal jet. The location of the jet is very important. We have several parameters, but for sure, the next step should be to define more current guidelines on patient selection based on more robust data. But at this time, it's still an individual decision.
But then, Axel, well, we have a really hot line with new questions, yeah. So there are 2 questions for you. First, how you decide for one procedure to the other, or are you using or even thinking in combined procedures? This is the first question. And then the second question, what is the goal for the treatment? So do you expect that it's going to move from torrential to mild TR after your intervention, as we ask for the surgeons?
These are really great questions, and they are tough ones too. I mean, we have to keep in mind that all of the technology that we are using now on the right heart side was basically developed for the left heart and modified by the interventionalist. And none of the techniques is still approved for the right side. So this is one of the challenges, that we don't have the optimized material yet. The other point is, what is the right time for treatment? And it appears to me that we are seeing a lot of patients far too late. So we have massive right ventricular dilatation, we have massive annular dilatation, and the devices that we have available are already at the anatomical limit. So if you have no coaptation left and there's a gap in between the leaflets of 5 to 6 millimeters, it's impossible to treat the patient. And then if you want to address those patients, especially those with very large annular dilatation, I think it needs the combination of techniques, like an annuloplasty device, for instance, suture-based, or ring-based technology combined with an edge-to-edge repair. We don't have data on that. This is just my personal opinion. With regard to the treatment effect, I think if somebody comes from, torrential to severe, and this is a patient that would have been operated, we would send back the patient to the cardiac surgeon saying, this can't be your truth. On the other hand, I mean, we have to be as fair on the interventional side. These are great technologies, but I think if somebody is coming from torrential, we should at least finish the procedure with moderate. And if this cannot be achieved, I think we should consider a combination of therapies.
And there is another question I think it's for you, but any of you can also answer. So before qualifying a patient for transcatheter tricuspid regurgitation procedure, what do you ask for the medical treatment? I mean, when do you decide, well, medical option is not any longer valid and I should go for transcatheter procedure?
Yeah, this is a tough question too, because we don't have basically guidelines, medical guidelines on right ventricular failure in particular. I think in general, to all of the patients that have ventricular dilatation, the heart failure guidelines with all of the medications appear, and this should be optimized. However, we are often seeing in patients with severe TR that titrating ACE inhibitors or titrating diuretics is some kind of difficult to achieve because patients often go into renal failure. So this is an individual decision that has been taken by the heart team. I think medical treatment with regard to heart failure treatment should be optimized, and all of the other things that you could do with regard to device therapy. But if this all fails, then I think it's time to discuss an interventional tricuspid treatment strategy.
And there are questions and questions, but I need to ask you another one because it's very pertinent. So we are treating more elderly patients. So we do see patients with pacemaker or advanced heart failure with ICDs. Is this a contraindication for the treatment?
No, definitely not. I think what we have to rule out first is of whether the pacemaker lead itself, or an ICD lead, is responsible for the TR. If this is the case, then I think we have to consider replacing the lead or implanting an epimyocardial lead. If we are sure that this is not the reason, it's just a coexisting factor that patient has a pacemaker, then we can evaluate what is the best treatment option, edge-to-edge repair, or even an annuloplasty device.
Excellent. I think that we have great cutting-edge information from the cath lab. Now is the turn for the operating room. So what is the surgical treatment for patients with TR?
Yeah, so I will just go shortly through this because, of course, most of you might be cardiologists. But one thing I wanted to make clear is that in combination therapies, together with left-sided heart, especially mitral valve surgery, we now have clear lines. Every time we see in tricuspid valve annulus above 4 centimeters in diameter, then we do repair the tricuspid valve, no matter if it's moderate TR or severe TR. This has now been done in the majority of cases and should always be done by surgeons doing mitral valve surgery. There are many ways on how to repair tricuspid valve. Basically, annuloplasty is the major part of it. There are suture annuloplasty techniques and ring techniques of various kinds. But there are also other techniques, and like the Clover stitch that I was pointing to beforehand, the K-plasty, somehow bicuspidalization of the valve, the double orifice technique, or what is important in my eyes, leaflet augmentation techniques, especially when it comes to tethering of valves. And it is funny enough that some of them are now being imitated by the interventional technologies we discussed today. And but we also know, and this we should have in mind when we do this, not all of them performed well in the long run. We know quite well that, for example, suture annuloplasty is not as effective as ring annuloplasty. So basically, with every tricuspid repair we do a semi-rigid ring these days, and we might combine this with other techniques if needed. This is the decision tree of our guidelines from 2017. I want just to highlight one thing. So if we now speak about isolated tricuspid regurgitation, so we should not speak about patients who undergo mitral valve surgery in addition. So if we have this and severe TR, And it's in the absence of primary TR, so it's secondary TR, and patients are markedly symptomatic, then we have an indication to do isolated tricuspid valve repair. And this is something new. We should do this under special circumstances after discussion in the heart team, because not every patient might be suitable, but it is an important option that we have. But there's things we don't know actually, so finally there's not much data out on functional TR. And I personally am very interested in the results on a larger scale of minimally invasive heart surgery in tricuspid repair. This is a case that I brought for you. It's a fully endoscopic 3D vision beating heart technique to repair the tricuspid valve. And this is really minimally invasive also in terms of patient invasiveness. So I guess that this kind of surgery might be much harmless compared to sternotomy arrested heart surgery. But there is a surgical conundrum, I have to confess, and being a surgeon myself, I also feel a bit guilty, because in the past we missed to do randomized trials. All the data we have is coming basically from single center retrospective data, no core labs, no data safety monitoring boards, anything. So there's a clear need to hook up and to also maybe in the future make surgery a part of randomized trials and compare this to newly developed transcatheter-based techniques.
So then, what is the goal of your treatment? Is to reduce from massive torrential to mild, or what is your goal?
Well, the goal should always be to go to mild or even no TR. In specific patients, you might want, if there is severe right ventricular dysfunction, you might want to intentionally leave a moderate TR in order to have this ventile that gets the blood back to the atrium. Maybe this helps. But this we do sometimes in very rare occasions, more or less in combination with mitral valve surgery, but it's not a usual thing to do.
Alan?
If I may add, for the goal is to restore a good surface of coaptation.
Yes.
It's also one of the basic rules for valve annuloplasty and valve reconstruction, like for mitral. And for sure, one of the very important criteria, I think, not only for surgery, but also for the band, should be to obtain the best coaptation at the end of the intervention.
So then, if we want to obtain the best coaptation post-procedure, what do you think is the best way to do that, to achieve that? Or is it depending on the patient, or?
Yeah, it depends on the underlying pathology. If it's just ring dilatation, a ring is all you need. But if it's tethering, then you need to do more. And this would be leaflet augmentation, as you figured out in your first presentation. And this is not such a difficult technique. You would always augment the anterior leaflet, place a patch of pericardium there, and then you all of a sudden have a much larger coaptation area. And this is what's needed in these patients.
And again, what is, you clearly show with the video, where is the future of surgery in the mini-invasive and beating heart. What is the risk of the patient? What is the mortality rate? What are the complications?
In these patients, if you exclude those with very severely reduced RV function, the mortality is close to zero.
Yeah.
And the risk is also very low.
Excellent. And there are questions coming for you. What are the contraindications for surgery? Why not to do a surgery?
There are not too many contraindications. For the minimally invasive technique, severe atherosclerosis might be a contraindication because you have cannulation of the femoral vessels. This would be a contraindication, but there are ways going around it actually also. Otherwise, it's just, again, the RV function. That's the only contraindication I see.
Axel?
Hendrik, how concerned are you about liver dysfunction? A lot of those patients have congestion. You know, they do not that well after heart-lung machine bleeding complications. Is this still a concern, or is this something from the old days?
I think it's still a concern, but actually having the heart-lung machine also has an advantage because the weaning process is in your hands. You can wean the patients pretty slowly, and you can even put them on ECMO for a couple of days to have this weaning ongoing for a couple of days. And doing so, I think we have a good chance to treat also those who have problems in the first hand with congestion and potential liver disease.
Yeah, there is no doubt that working in the annulus is very attractive for our audience, and there are two questions related to the ring itself. So the first question is, what is the difference, clear difference between rigid and non-rigid ring, and how you decide it?
The rigid ring usually has a 3D shape that also then resembles a better coaptation area. As Carpentier told us, and Alain repeated today, it's all about coaptation of leaflets. So a 3D shaped ring that must be a bit semi-rigid, otherwise it cannot keep its 3D shape, is important to achieve this goal. Bands, I personally never used them, and I would not recommend to use them. I know some people do. But a band is not comparable to, for example, to the cardio band, because the cardio band, due to the metallic structures of the screws, once you cinch it, becomes pretty rigid.
Yeah, and then Axel, I mean, if Henrich implant a semi-rigid surgical ring, this will work for potential later transcatheter valve in ring?
Potentially, yes. It depends a little on the size that he's implanting, but if it's small enough, then it should work.
Excellent. And what is your experience, Henrich, in the right ventricular failure after the intervention, and also even after surgery or after transcatheter intervention? So, on how to overcome right ventricular failure?
Yeah, fortunately enough, these days we have techniques to overcome the problem. Sometimes we see this, and then we are taking profit of having, for example, impeller technology. Impeller for the right ventricle is a great thing that really brought us forward in these kind of patients. There are also special ECMO-like techniques with double cannulation, but just for the right heart. But what we usually use at our center is the RV impeller.
Excellent. So I'm going to ask you all the same question. Here is a clinical case from one of the people sitting in their hospitals or home. Patient has a functional severe mitral regurgitation and torrential TR. How are you going to treat him or her?
So I would address both valves at the same time.
Same time?
Yes.
Percutaneous, both?
Percutaneous, yeah.
Alain?
If there is no contraindication for surgery, I will treat both at the same time with a double annuloplasty, mitral annuloplasty or replacement, or tricuspid annuloplasty or replacement. Again, it depends on the tethering. That's the key. That's why echo is critical in the pre-op evaluation, the degree of restrictive motion and the tethering effect. That's a key which makes a difference between the stage 2 and the stage 3. If there is a contraindication for surgery, I will go obviously with transcatheter therapies and probably with a combination in procedure.
And if, let me go deeper. And if there is no contraindication for surgery, will you consider sending the patient to Axel?
If there is no contraindication for surgery, and again, it's very important to remind the heart team discussion. This type of patient is so difficult. We have to have a consensus between the different specialties. We need a surgeon, we need the interventionist, we need the imaging, we need also the geriatrician. It's a very important concept, and it's key in this type of discussion to have a very hard team decision.
So, Henrich, I presume what's going to be your answer, but let us tell the audience: severe functional mitral regurgitation and torrential massive TR. What are you going to offer this patient?
I think you might be wrong. It's not such an easy answer, actually, because if it's severe functional MR and TR, these are very sick patients.
Exactly.
And usually I am not licking my fingers to get them on my OR table. So I'm very happy that I have the chance to work with one of the most experienced interventional cardiologists in my center, it's Georg Mickenig. We would have a good discussion on this one, and we might finally decide to do him interventionally, and I would be absolutely standing behind him. That's fair enough. But it's really, as Alain said, a question of the patient.
Okay, we're going to move, and now we have implanted how to monitor the procedure.
Yeah, thank you. I think we are not going to talk about general aspects that are clear to everybody. For tricuspid interventions, most of the patients are still intubated because there is TOE echo guidance required throughout the procedure. And some of the procedures are still very lengthy, taking 2 to 3 hours. So doing this in conscious sedation is technically possible, but most of us use general anesthesia, which require recording of blood pressure, CO2 content, O2 content, oxygen saturation. In addition, most of the tricuspid procedures are very complex, and the planning is close to a planning that you have to do before you take off with a plan. You're seeing here a CT reconstruction from a tricuspid annulus and a patient that's intended to be treated by a Cordiband. And as you can see from the right side, you can see the view, the en face view on the tricuspid valve. You can see the aortic valve far up in the right, and then the different anchors that are supposed to surround the tricuspid annulus and the way the Cordiband is going to take at the end. You can appreciate by the green line the proximity of the right coronary artery. And when you drill in the anchors, you have to make sure that you're not hitting the right coronary artery, causing bleeding from the RCA, and you're also not willing to hit the aorta. In addition, it's very important to set the first anchors in the right spot, because if you're too far away from the annulus, too far away from the aorta, you will not have a good contraction at the end. On the other side, you don't want to hit important structures like the aorta itself. You can see on the left side the aorta as indicated by the yellow ring, and the placement of the first anchor with a distance of about 2.5 centimeters from the center of aorta. And all of this planning is done pre-procedurally with the help of a CT scan. This is all necessary to have a good treatment effect at the end and to prevent complications. This is just an angiographic view. You can appreciate the right guiding catheter. You can appreciate a coronary wire that is in the RCA just to track the RCA during the procedure and avoid too many contrast injections. You can see that the first anchor is just placed exactly where we wanted to have it. And you can see the 3D TOE imaging on the right side with the catheter just pointing to the tricuspid annulus close to the aorta. So this is key to guide the procedure and monitor the success of the procedure. There's further advancement being expected from the use of ICE technology. Especially in the middle segments of the tricuspid annulus, we sometimes have poor visualization and cannot distinguish where to place the anchors exactly. So we're expecting from the introduction of ICE technology a better imaging on the tricuspid valve, and we're expecting to facilitate and speed up the procedure in the interest of the patient. And then at the end of the procedure, when all of the anchors have been placed, you're in a process to contract the band and reduce the annular diameter. And as you can see here now, before the contraction, after the contraction, is the right coronary artery that is unimpaired in this patient, and you can nicely appreciate the reduction in annular diameter. However, in some of the patients, we are seeing a kinking of the RCA and sometimes stenosis. We haven't well understood in which patients this exactly happens, and this is process of further investigation. To rule this out, you need good imaging by echo and by angiography to prevent complications.
Axel, let me ask you in this slide, do we see this kinking of the right coronary artery after surgery, after the annuloplasty? Is this normal? Is this related to what?
Yeah, this is a very good question. Whenever I was forced to do a coronary angiography as after a conventional cardiac surgery procedure, for whatever reason, I've never seen such an effect. So I think it's specific to the procedure, and probably Hendrik can give us more insights why he thinks this occurs with this kind of procedure, but not with cardiac surgery.
At least I'm not aware of it, because we don't, of course, not usually do coronary angiograms right after surgery. Maybe it's also something that resolves over time, and at the time point you do the coronary angiogram, it's no longer there. So I don't have the answer, to be honest, but I think it may have something to do with the screws that are 8 millimeters that may just go closer to the RCA, and then also the pulling forces. There is a difference in technique when it comes to annular reduction between surgery by sutures and screws with the cardioband.
But then let me turn the question to a clinical perspective. In your experience, after the procedure of a cardioband, with no problem during the procedure with the right coronary artery, do we see during the follow-up inferior ischemia, or did you notice that something happened in terms of ischemia for the patients after the procedure, 1 month, 2 months, 3 months later?
We haven't seen this yet. I think the challenging clinical question is when you have implanted a band, you contract the band, and while you contract the band, you're seeing a stenosis or even an occlusion. There have been a couple of cases, and in this case, a stent was placed and then the band recontracted without problems. The other point is, if you contract the band and you're seeing some kind of kinking, how to follow. And this is basically the intent of further studies to understand how we should deal with those kind of constrictions. There is some early experience showing that those stenosis are disappearing over time, at least in some patients. And the theory is because the RCA is basically running in some kind of fit tissue surrounding the ventricle, that this is settling down within the next days to a few weeks. And this is the reason why the stenosis might disappear. But we have to understand the process better.
Yeah, this is very interesting. So in summary, you don't recommend a stenting at right coronary artery if the patient is asymptomatic and you see a kinking?
Yeah. If there's no evidence of ischemia by ECG changes or a massive reduction in flow as determined by naked eye, then I would not stent the vessel. If there's occlusion, then I think definitely the band has to be decontracted, the stent to be placed and recontracted afterwards.
Please.
And this is basically the final result. You can see the TR on the echo view on the left side before band contraction and after full band contraction. And in this case, you can appreciate that the severe TR at least went down to mild stage. Thank you.
Excellent. So, but we do have many questions for you. Yeah. So coming from the audience. So let us imagine that we have a patient with tricuspid regurgitation that is secondary to severe MR. Don't you think, since this is the people or the patient usually has a functional TR here, don't you think that it makes sense to treat first the MR and then wait and see if you need to treat TR later?
Yeah, this is a good question. It's always something we discuss in the heart team in real clinical practice. I think if you have biventricular disease with tethering on both sides, just fixing the mitral valve is not going to solve the problem on the right side, although we wish this is going to happen. And I think there's a lot of evidence from the surgical literature. If you have combined disease and you're solely treating the mitral, patients have an inferior prognosis as compared to those where you treat both valves at the same time. And I would not see one reason why this should be different just because we're using transcatheter techniques.
Alan, question for you. How to evaluate the right ventricular function after the therapy? And I will say therapy, surgical therapy, and transcatheter therapy.
Before or after?
Before and after, yeah.
As you know, by echo, we have some limitation, which are basically the same as the CMR because it's very loading conditions, effect, and at this moment, CMR is a gold standard. However, after device implantation, it may have some difficulties to evaluate post CMR evaluation with this device. I don't know your experience. However, by echo, we have also some progress, like a 3D evaluation. We had recently a meeting with Luigi Badano, who clearly showed very beautiful result with 3D echo with automatic detection. And I think we have to go in this direction in the future.
Yeah, I fully agree that even auto strain of the right ventricle may help. And then a question that is coming, with Cardioband, can we do an MRI?
You can, yes.
Yeah, so this is clear. It's not a contraindication for that. And well, Henrik, another question. Do we have difference in terms of outcomes related to gender? So it's females or males, different results, or?
Not that I'm aware of, actually. It's a good question. Usually, sometimes female do a little worse than male, but I have no data, actually. No, I don't think there's something published in the literature.
And then the immediate question here, and this is from me, you said sometimes females, they do worse than males. Are we treating them later?
Maybe yes. That might well be the reason.
Okay, so then we need to move to the what is in the future, and I think that I think that we have a portfolio of different things. So, Alan, what do you think that we should know to differentiate? So we have a clearly menu of different things to do in these patients, and I'm going to ask you, all of you, your vision, how to decide, how to select what to offer. So you said about the right ventricle, the tenting, the tethering. So what do you think is crucial? Because now we have in front of us so many things, so new things that we need to decide what to do.
It is probably the next challenge for consortium to have produced guidelines like we have for mitral or aortic. Clearly, this work has to be done now. I think it's mature to do this work. Again, it's an individual decision at this moment. We have several options. We have seen the determinants and the information we may have from multimodality imaging. And again, we cannot have one answer which can say, okay, this patient is for this option. It depends on local resources also and centers, on the experience of each center on edge-to-edge or band. It's very important to consider, again, very importantly, the heart team discussion. And in my mind, we may have different categories of patients who may benefit from this technology. Clearly, for me, the late TR after mitral valve surgery is probably a very good option. Surgical TR undergoing edge-to-edge repair. Post-heart transplantation is also a patient which can be very challenging. High risk with patients with severe EAS undergoing TAVR. We have some patients with severe TR with aortic stenosis during TAVR. PM lead induced tricuspid valve disease. Elderly patients, particularly the female patient with long-standing AF with idiopathic TR, is probably one of the most challenging patients. And again, after surgical tricuspid repair, we have some off-label experimentation of valve in a ring, and I think it's also a very good challenging issue.
Hendrik, so how to select? What do you think is real? We have in front of us surgical options, transcatheter options, many different devices. How will you approach the final decision?
The final decision is a heart team decision, because not every patient is like the other. But I'd like, since I'm here, I'd like also to pave the way a little bit for surgery, because surgery has been mistaken as something dangerous when it comes to tricuspid regurgitation due to the bad data presented in the past. But surgery has also changed. And as Alain pointed out, first of all, the first step would be to define the outcome of such trials that we need to do. And this might be a TVAR recommendation committee again, as we had it for the mitral and the aortic valve. This is now due time to set this up. Then we should make surgical control arms part of our investigation here. We should not only compare the new interventional treatments to best medical treatment, we should also have a surgical arm for those who are not high risk for surgery, of course. So there are some patients who just disqualify for this, and they should be then, of course, only be compared to best medical treatment. But I see a point here for surgery, because if we can treat the tricuspid regurg completely and resolve it, it's better for the patients in the long run. There's no doubt about it. Then we should have a look for registry data. That's good, that everybody who does something at the tricuspid valve today should enter the data into a registry, that we find out what is really the all-comers outcome of everyone. And maybe we should also go one step forward and go earlier with the treatment. If we, this is, as Alain pointed out, maybe we're always too late. If we come earlier, we could also set up a study comparing early treatment to watchful waiting, and then see if that has a positive impact on outcomes. So many things to do. And once we have this data, I think there might be a chance to also update the guidelines, because the guidelines today do not touch the topic of transcatheter treatment at all.
Yeah. So Axel, then you have different devices, different things, how to select, including surgery.
Yeah. Yeah, I'm absolutely in mind. I mean, as long as the patient is not high surgical risk or inoperable, I think that the treatment of choice is surgery. And as Hendrik pointed out, the results have been really gotten better during the last decades. If the patient has no surgical option or is considered too high risk, I would always, if this is technically possible, go for an annuloplasty strategy. Because if this works, it's good for the patient. If not, I still can go with a valve or with a potential new transcatheter valve into the annulus, and I can do edge-to-edge repair technique later on. If I start with edge-to-edge first, then all of my future treatment options are some kind of impossible or uncertain with regard to whether I can use it or not. This is how I would see it. And the additional point is, and I'm with it to others, we have to understand here first if there's a similar cohort C like it was in partner. So patients where the right ventricular function is too much impaired that are not going to benefit from any kind of valve intervention that might benefit from a assist device or whatever, a kind of treatment, or only a palliation. And to identify those that might have a clear benefit even in the early stage of the disease and in the severe stages of the disease.
Alan, very briefly, because we have a few minutes left, but there is a question that is coming, and I think it's for you. So, as we have seen with mitral regurgitation, this concept of disproportionate MR, do you think that we should talk about disproportionate TR according to the right ventricle?
It has to be evaluated. It has to be studied by the MRI with volume quantification and particularly indexed volume and differentiating the women and men. But for sure, it is an interesting concept mimicking what we have learned from the mitral studies recently published. Yes.
So we have 3 minutes left, so I'm going to ask you for a final conclusion. So what is, Hendrik, your final message to the audience that they were very active, and what is your main message?
Well, I'm very happy that we're now taking so much care about the tricuspid valve, what we haven't done for such a long time. And it's also great that we have so many new devices coming on board that will help us treating patients that are not good surgical candidates. I'm also very happy that the surgery is developing to a more advanced stage with beating heart techniques and everything. So yes, I feel pretty comfortable, and I hope that with the coming years we will gain so much experience that we can treat our patients much, much better.
Alan, final message.
Final message is look at the tricuspid valve in your echo and elaborate on tricuspid valve, on right ventricular function, on annulus, on coaptation mode, and it will permit at least to classify the patient in the 3 stages.
Axel.
I think we have some promising new technologies, but they're not perfect yet. We are in very early stage. We're in a learning process, and this is the reason why surgery is still first, if this is possible. On the other hand, I think, and I'm with Hendrik, we need randomized trials early on, and I think we should start probably not with the one that are the worst and where our transcatheter techniques are inferior to surgery because we just can't address the anatomical issues, but maybe with an intermediate cohort of patients and understand compared to surgery or to medical treatment, if you're going to improve prognosis of the patient.
Well, I hope that you all enjoyed the webinar. I really enjoyed. It was for me a luxury to be with all of you. But we have seen that TR is relevant. I mean, TR is relevant because impact in the prognosis of the patient. We need a better diagnosis, no doubt, because it's not only the valve, as Alan said, it's the annulus, it's the tethering, it's the right ventricle, it's the pressure, it's the status of all the comprehensive part of TR. We have seen enormous advance in surgery, minimally invasive surgery with results that for sure maybe this mortality is too old, as it was highlighted by one of the people in the audience and also here in the PCR studio. We have a huge variety of potential new treatments, as Axel has clearly demonstrated. And we need to work in the heart team to select the better treatment option for the patient itself. I want to finish with a few sentences that I pick up from you all. And Alain said, probably we send patients too late. Axel said, we have seen a lot of patients far too late. And Henry said, well, the goal should be non-TR or very mild TR. So in fact, we need to consider that when we have a patient with TR, we should diagnose early, treat early, maybe is the best way for the patient. Thank you very much for attending this webinar. I hope you enjoy and hope that we will not close the webinar here. We keep tracking your questions and we are ready to help. Thank you.